Welcome to this edition of the Town Hall. We are happy to have all of you here. If you're attending for the first time, this is the Cameroon Town Hall for healthcare professionals. We meet every 2 weeks to discuss on health topics that are important to our healthcare system in Cameroon. The Town Hall for Healthcare Professionals has been existing for the past 3 years today, and we've never skipped a session, thanks to the leadership of our chair, Dr. Muno, and all the moderators who work really hard to make sure that we have all these sessions going on. Today, I shall have the pleasure of co-moderating with Dr. Matt Sandrine Polo, who is going to be our co-moderator in French, and hopefully we are going to get Dr. Brian Tegoma, who will be joining us subsequently. We are still in the Breast Cancer Awareness Month, and today we shall still be talking about efforts to fight a curable disease. And today we shall be looking at who is doing what and some of the most interesting things that are going on in the country. And we have a very important stakeholder in this sector, Sidney Tazeh, who not only is passionate about this, but also has a structure in place in Cameroon that is providing, diagnostics for breast cancer in Cameroon and other radiotherapy that you can think about. So I think this is really an important topic, and I'm expecting a very full house today each time we are talking about cancer, a topic that our chair is very passionate about because he's an oncologist, and so he's really one of the trusted authorities too that will be adding his voice to today's session. So once again, welcome to this session, and hand over to Sandrine for his welcome intro in French. Bonjour, Sandrine.
Elvis, merci. Bonjour à tout le monde. Aujourd'hui, c'est la 111e édition du Cameroon Town Hall qui a commencé il y a 3 ans aujourd'hui. Donc, merci au docteur Mono qui a dirigé cette initiative depuis les 3 dernières années. Aujourd'hui, nous sommes dans le thème du cancer du sein parce que c'est le mois de sensibilisation au cancer du sein. Alors, nous avons un présentateur aujourd'hui, Sidney Tazeh, qui va nous entretenir en fait sur cette maladie dite curable, selon son titre. Alors, nous avons hâte de savoir quels sont les traitements qui sont effectivement proposés pour guérir la maladie. Dr Sidney Tazeh est physicien radiologue. Dr Mono a présenté il y a 2 semaines sur le cancer de la prostate, donc c'est une très bonne continuité. Mais je voudrais rappeler qu'il a aussi souligné qu'il y a plusieurs professionnels de la santé qui prennent soin du cancer, notamment des physiciens radiologistes. Donc, nous sommes heureux d'accueillir Dr Sidney Tazeh aujourd'hui. Dr Mono, je vais passer la parole au chair de la session.
Wow, thank you very much, Dr. Sandrine, Matt, for giving me the mic. And I'm very grateful today to have no one else other than Sidney coming here for us to talk about the actions that people are doing on the grounds. A lot of people may not know this, and Sidney loves to be very humble, doesn't want to be introduced about the wonderful things he's doing back home, but I'll just split the things here, Sidney. The thing is, if you want to talk about someone who is a doer, who doesn't just talk about things but does things, that's the person you're looking at. These are the change makers that Cameroon needs. Sidney is one of them, and Sidney is passionate about health, not just about cancer, but about health overall. He's passionate, especially about cancer treatment from his work he does in Tampa, from his educational background, and working as a medical physicist. And he's super passionate about changing healthcare in Cameroon. So right now, thanks to Sidney, we do have an ultra-modern structure in Boya called Clear Radiology, where for the past years, he has not allowed me to really talk about this openly, but for the past years, he's been not only screening all cancers, but has a vision which is bigger than you can imagine. It's a vision to expand and provide accessible, free healthcare, which is affordable and also provide screening, what we've been talking about here in the town hall, screening for all diseases before we actually get to have them. So more about primary prevention. So the reason we contacted Sidney and plead for him to come to the town hall today is to tell us those who are engaged in breast cancer fight in Cameroon, what is happening? What are the things that we're doing in terms of healthcare and breast cancer? I think it's a time for us to actually appreciate things people do and see what we can do going forward, and where everyone can contribute, put their own little donations to some of these groups and get us where we think actually in Cameroon. So, yeah. Okay. So, yeah, there was some noise. So we are going to have detailed training. I'm going to do training. I just wanted to let this out. Training next week. It's still under the town hall, partnership with the town hall. Yearly, I do a series of breast cancer training lectures. That is meant for physicians, for oncologists, for radiation oncologists, those who are back home, for us to discuss what we can do. So it's an updated training, which we do. I will do that on Saturday and Sunday. It will be a series of 4 lectures, 1 hour each. And it's meant for medical students, fellows, residents back home in Cameroon, nurses, and everyone else. So I just want you guys to join us. We'll send out the adverts for that next Saturday and Sunday, same time as the town hall, for us to discuss detailed treatments of breast cancer and the way forward. So thank you very much. And I will be here. I'm passionate about breast cancer. I'm passionate about all cancers. My subspecialty is actually cardiothoracic, which is the lung and the heart and the head and the neck. That's what I do at my practice most of the time, but all of us do treat breast cancer, but that's my subspecialty of research. So over to you, Elvis and Dr. Matt Sandrine.
Yeah, thank you very much, Dr. Mona. It's really always very interesting to bring a topic like this. For a quick reminder, breast cancer is one of the most prevalent cancers affecting women in Cameroon, and its magnitude has really steadily been increasing in recent years. And we all know that some of the factors that contribute to the growing burden of breast cancer in Cameroon include limited awareness, and also issues of late-stage diagnosis and insufficient access to healthcare services. So we shall be hearing a lot on some of the approach in which Sidney and his team are using to solve some of this problem. The mortality, breast cancer mortality, has really been steadily high in Cameroon, and data indicates that approximately 13.4% of all cancer deaths in Cameroon are in women. And this was a data that was documented in 2020. So this is a very important topic, and over 60% of women with breast cancer in Cameroon are diagnosed at an advanced stage. Just to set some basic data for you to see how important this is. Sandrine, do you agree with this data?
I do. I want to talk about the brighter side. If you look at the US, je voulais parler du rayon de soleil dans le cancer du sein, parce qu'Elvis vient justement de mentionner des chiffres qui sont alarmants, avec plus de 60% des femmes qui sont diagnostiquées à stage avancé du cancer du sein au Cameroun. Et je mentionnais justement qu'il faut qu'on regarde du côté rayon de soleil, qui est effectivement les chiffres aux États-Unis, où on parle ici de 90% des femmes qui sont diagnostiquées à stage précoce qui survivent. Alors, le titre aujourd'hui de la présentation, c'est une maladie curable, le cancer du sein. Donc, on veut comprendre comment est-ce qu'on peut arriver à ces chiffres de 90% de femmes qui survivent au Cameroun. Ça commence par le dépistage, et Sidney Tazeh est non seulement quelqu'un passionné pour la médecine, mais particulièrement qui a apporté des solutions de terrain au Cameroun, notamment le centre de radiologie d'imagerie à Boya et Claire. Et nous sommes, en fait, moi particulièrement, je suis très intéressée à entendre comment ça fonctionne et quelles sont ces solutions curables qui sont sur le terrain. Et aujourd'hui, c'est un sujet très intéressant pour le dépistage, parce que nous sommes dans le mois de sensibilisation du cancer. Mais je voudrais aussi rappeler qu'il y a des personnes qui sont atteintes de cancer. Donc, j'aimerais savoir aussi qu'est-ce qu'on fait sur le terrain, particulièrement pour des personnes qui sont atteintes de cancer métastatique. Donc, Sidney, Tazeh, nous avons le plaisir de vous entendre. À vous.
All right, thank you very much. Thank you, Madam Sandrine. Thanks for the introduction. Thank you, Dr. Muno, and thank you, Elvis. It's a pleasure to be back. I try to attend as many of these as I can. They're always very interesting, and this is my second time I'm doing a presentation in this forum. When Muno called me, I was actually scheduled to be in Cameroon today, but unfortunately, my state. I live in Tampa, Florida. We got hit by a hurricane that really caused some devastation, so I had to postpone my trip. But a little bit about myself. I'm a medical physicist based here in Tampa, Florida, in radiation oncology. And I'm going to go ahead and share my screen while I'm introducing myself. Let's see how we can do that. Let's see. Can you guys see my screen?
Yes.
Yes, perfect.
All right, perfect. So I'm Sidney Tazeh. I'm a medical physicist based in Tampa, Florida. I've been in the field for about 17 years now. I was board certified in 2013, so 11 years by the American Board of Radiology. And one fun fact is medical physicists are the only non-medical doctors that are certified by the American Board of Medical Specialties, which only certifies medical doctors. So we are the only non-physicians in that team. So I'm privileged to be in the midst of well, smart and like-minded people like Dr. Muno. So I mostly right now for the past 5 years I've been treating mostly patients with brain and spine cancers. But over my career I've treated people with breast, prostate, liver, adrenal, bone mets, pretty much any cancer, name it, I've treated it. Skin cancers, but obviously breast cancer is something that I have a passion for because of my personal history with breast cancer in my family, but also because I see an opportunity to make a difference in Africa. So I'm going to be talking quite a bit about the efforts that is being done in Cameroon right now by my organization, but also by others in Cameroon. Give me a second here. Let's go ahead and get this up and going. All right. You can see my screen. So it is Pink October, Breast Cancer Awareness Month, and for this talk today, I'm not going to talk too much about too much statistics. I think Elvis already gave us a few statistics, and I'm also not going to talk about like risk factors and things like that. I'm going to focus my talk mostly on things that happen on the ground. I think Dr. Muno is definitely much more knowledgeable, and he'll handle that next week and in other talks. But I'm going to focus on things that we're doing in Cameroon right now to fight this disease. Obviously, it's Breast Cancer Awareness Month, and breast cancer seems to be the one that is most talked about, and it can easily get monotonous. And I know in the town hall sometimes we talk about cancer a lot, and there are other diseases that we should be concerned about, especially communicable diseases in Central and West Africa. But breast cancer is definitely special because it does affect not just the physical health, but the mental health of our women and also our men. In the month of October, sometimes people feel like there's a lot more than just the ribbons that people will walk around and we put on our pink t-shirts or pink hats and we do walks. But there are real people out there who are suffering from this disease, real people every single day. And my goal is to see how the things that we are doing to help these women now, okay? Dr. Muno knows this. Every time I come to the town hall, I try to talk about practical solutions, things that we can do today to help women and men. And so that's what I'm going to try to do today. It should be a brief talk, and then we can have a long discussion about that later. After in the parking lot. A few disclosures. I'm the founder of Clear Medical Foundation based in Cameroon. I'm also the founder and CEO of Clear Radiology, which I'm going to be talking about. And all the slides that are here are my personal professional opinion. I'm calling from work right now, but I'm talking as Sidney, the global health advocate, Sidney, the father, Sidney, the brother, but also Sidney, a professional. So these are my personal opinions. The goals for today is at the end of this talk, I want to try to impart some knowledge to the attendees, because all those who are here, they're here because they want to learn, they want to make an impact in the care of healthcare in general, but for this month, breast cancer specifically. So every person attending this this town hall today, I want to try to make sure that they can leave going with at least one thing that they can do today to join this fight against breast cancer as we celebrate breast cancer awareness month. And again, like I said, with practical solutions that is being carried out, and it's making the difference in how we diagnose and how we treat breast cancer. So obviously, the reason I'm giving this talk is because these solutions are working. Like Dr. Mono said, I've been doing this in Cameroon for a while now. I go to Cameroon quite often, and tried been on the ground and really have had some difficulties, but finally we're getting some traction and we're really making a difference on the ground. So I want to show some things that we're doing and how this can be scaled up to impact more patients. Right now, we're only based in Boya, but we do have patients that come all the way from Douala, even as far as Yaoundé. But of course, Limbe, Kumba, around the southwest and northwest. But we obviously are going to impact Cameroon and West Africa in general. So why breast cancer? And I'm just going to spend a minute and talk about this. I strongly believe that for all cancers, prostate, colorectal, cervical, breast cancer is the one which we can make an immediate and long-lasting impact. Infectious diseases are there, but breast cancer is different because compared to other cancers or infectious diseases, breast cancer carries that doom and gloom that you get when you have a diagnosis. People are still afraid of it. But when this is the study that came out of from the UK, looking at all cancers and why breast cancer is specific. Because if you look at the 1, 5, and 10-year net survival for all cancers, breast cancer is probably one of the cancers that has the highest survival. I think only prostate cancer is almost on par with breast cancer, and then of course melanoma, which is skin cancer. But we all know that melanoma is not that big of it. It's not the prevalence of melanoma in Cameroon is not very high. So we want to look at the cancers that are actually a problem in Cameroon, because we know breast cancer is still the second killer among women when it comes to cancers. So yeah, we're looking at almost a 92% survival when it's as far as 99%, because I think this study was done almost 10 years ago. So right now it's about 98% survival if breast cancer is diagnosed early. So it is very curable, and it's one of the cancers that we can really make an impact. But let's also look at things that have happened over the last 30, 40, 50 years. If you look at this graph, the pink is my breast cancer. You can see that breast cancer, when it comes to relative survival, is significantly higher than all the other cancers, and the trend is continuously going up. It's going up, going up. So not only can we dial into this problem because we see that improvements are being made all over the world, obviously except sub-Saharan Africa, where studies have shown that 75% death in total in the whole world by 2030 is going to come from Africa. 75% of death. So we're trying to see how we can get ahead of this problem by actionable solutions on the ground by some of us who have been trained in America and want to go back and help out. So breast cancer is curable. I mean, that's one thing that I've been hitting at home ever since I laid foot in Cameroon 5 years ago with my project in Cameroon. People should know that breast cancer is curable. It's not a scourge. It's not a taboo. It's not something that you should be afraid of. When diagnosed early, breast cancer has a very high rate. And there are 5 different ways in which we treat breast cancer in the world, via surgery, via hormonal therapy, targeted therapy or immunotherapy, radiation therapy, of course, which is my specialty, and of course, chemotherapy, which Muno is going to talk a little bit about. Initially, this talk was going to be a conglomerate of a few other professionals contributing. I've got some of my partners in Cameroon. Hopefully, they're going to be online soon. They just finished a big campaign I'm going to talk about. And then Dr. Muno is also going to chime in towards the end. But all these treatment modalities are, except targeted therapy, surgery, hormonal therapy, chemotherapy, and radiation therapy, is very accessible in Cameroon today. I'll say just 2 years ago, some of this was not available. Like radiation therapy was really hard to come by, but now we have good radiation therapy that's available in Cameroon. So I'm going to talk about some of these. Not only is breast cancer curable, but I'm going to make a bold assertion that it's relatively easy. And I'm not saying that it's a walk in the park, but when caught early, breast cancer, yes, is relatively easy to cure compared to every other cancer, colorectal, cervical, brain cancers, or lung cancers. breast cancers are relatively easy to cure, but they are also less costly compared to other cancers. So this is something that we can really make an impact on. And I always have this slide on all my talks. I'm a global health enthusiast advocate, and I know we come from Cameroon, West Africa, where things are not always the best. We don't have the best state-of-the-art treatments and the best state-of-the-art equipment like we do in the US. But I work on the mantra that please, whatever we do, let's not let perfection be the enemy of the good, right? We are striving for progress, not perfection. One thing I learned in my career from college, high school, especially when it comes to the US, is that things, when you build, people come. That is true 99% of the time. And things are changing in Cameroon. Let's not be discouraged. We have a lot of challenges, but I can testify, first-hand knowledge, that when you build and you show people that something can be done, and you come with it from an honest perspective, and you're dedicated to it, people will join you. And I can see that that's happened, and it's happening every single day since I started going to Cameroon. Our efforts, of course, we started as Clear Radiology, but just in the last 7 to 9 months, we've had a lot of other people join us. And we had a big event today in Boya where all these groups all came together, both in the private and the public sector. And these are just some of the people that I'm going to talk a little bit about some of them, but mostly about what Clear, the company that I founded, is doing in Cameroon. But all these people are actually doing work right now, non-for-profit, just trying to make life easy for the men and women who are suffering from breast cancer. And the biggest thing that I've really seen made a difference is that collaboration. And that's one problem that we Africans have, and especially Cameroonians. I'm just being honest. We don't collaborate as much. I'll tell you that when I started this project in Cameroon, my first partner was a Ghanaian who wasn't a Cameroonian. And he's still a partner with me today, and he does all our tele-radiology services. But I'm glad to also report that ever since then, dozens and dozens of Cameroonians have joined, including the members of the town hall, who have been very, very supportive and who've been there. This collaboration is key to our success. We still have a long way to go, but Lord behold, I'll tell you, things have been, it's been very rewarding. So I'm going to talk about the efforts. I'm not going to go too much into Clear as an organization as far as all the services that we offer, because again, this is Breast Cancer Awareness Month. I'm going to try to focus on breast cancer, but obviously I'm going to mention a few things about how we operate, because obviously Clear is at the top, and then we have all these other organizations around that we're all working together. And we are kind of like the leaders, pushing, especially from the private sector. We have some flexibility that others don't have. So that really gives us that role to lead the community. But that collaboration has been very key. So this is like a little some of my staff at the clinic. One thing I'm going to say is which has been working for us is that we have a very young staff. Nothing against the older people in the room. Age is wisdom, and sometimes they say youth is wisdom in the young. But we have a very young staff, and they are hardworking and they are well trained. I go to Cameroon quite regularly to train these people so that we can offer good quality and compassionate medicine in Cameroon, which meets standards, standard of care. So my staff is young, well trained, and what we've done in Cameroon is that we have offered a complete solution for breast cancer. And what do I mean by that? In many parts of Cameroon and even in Africa, they do a lot of sensitization, awareness, and screening. But very often it ends with awareness or screening. People don't know what to do. Okay, a grandma will say, Sidney, I'm going to, in Pidgin, okay, if I know that I have cancer now, or wait, I will do. So that causes some people to shy away. And if you only screen people and you find cancers, but you don't have a way to tell them on how to get treated, then that's a problem. Okay, but Claire has been able to come up with an awareness plan, a screening plan, but also accurate diagnostic services that we offer in the clinic for breast cancer, and but more importantly, how to manage a disease. Because now you're diagnosed, then what happens next? Number 4 is obviously the most important, because there's no point diagnosing me if you're not going to help me. But so Claire has worked really hard to offer patients a way of managing their cancers. Another part that is not talked about, which is super important, is triaging. And Dr. Mono and I will talk about this so many times. Who gets treated? Who doesn't get treated? who should get an MRI, who shouldn't get an MRI, who should get a CT, who shouldn't get a CT. That is one critical role that Claire is playing right now, and we can all play, us here in the town hall, guiding patients so that those who need treatments get treated, and because our resources are limited, so we cannot just go ahead and scan people left and right and order tests and give medications that they don't need. It's very important, and that's a big role that Claire really shines in, because we've got people in the US and Cameroon that we consult with, we talk to, and we all guide these patients in Cameroon. So let's look at awareness, what Claire is doing in Cameroon right now for breast cancer as part of our complete solution that we're offering to the people of Cameroon. And obviously, like I said, this is going to expand to other parts in Africa. So for awareness, today is Saturday, October 19th. And like I said, I was supposed to be in Cameroon. My staff did a Q screening event in Cameroon, in Boya. And I'll talk about it a little bit. But obviously, the first thing we want to do is just, we are fortunate that we're located next to the medical college. So we're able to recruit a lot of medical students, final year students, to come and join our breast cancer efforts in Cameroon. And so the first thing we did was get them on board, and with a few medical doctors, and these are all third or fourth year final year students, and then a few medical doctors, and then we train them. Okay, we train them properly, and then send them out to the field to go where the patients are. And how do we do that? We started by going to the radio. Obviously, you have to know the target population. 20-year-olds, 15-year-olds, 18-year-olds, 21, 25-year-olds, they might not listen to the radio as often, but also they don't tend to get breast cancer as often, although that is beginning to change. But we know the grandmas in the markets, at and churches, our uncles and our aunts, they all listen to the radio. So the first thing that we did was to get people to go out there. Myself, I was out there to get on the radio and talk to people about awareness, talk about sensitization, what it is, and how. And now that the help is here, here's where you can go to get help. The help is available right now. You don't have to hide. So we decided to go up on the radio. And then, but also importantly, it's good to engage the local community. So this was 2 weeks ago. We obviously went to the paramount chief of Boya, who's a doctor himself, a very passionate guy about healthcare, and he supported the efforts, and he literally put the word out there, and you could tell the difference that people say, okay, chief is speaking, so we should definitely pay attention. But other than that, to engage the community, also sometimes you have to get there's a government structure in Cameroon and in every country. So October is also the International Day of Rural Women, and a lot of Cameroon is made up of rural women. And so what Claire did with the volunteers is that the whole of last week we went out into the inner cities, working hand in hand with the Women's Ministry of Women's Affairs, which is now called Ministry of Women's Empowerment. We go out to the community, the volunteers go out there, they talk to the people, to the women. But one important thing that the ministry did, which is because they trust us, is that they were able to identify, because they've been around a lot longer than us, they were able to identify the women that are of highest risk. They're impoverished and they have higher risk of breast cancer. And then they send those women to us, and then we're able now to go ahead and do the screening and any diagnostic tests at a significant discount, because we know that these women have been well vetted by the ministry, and now we are there. We let them go and get these clients, these customers that they've known for 10, 20 years, and then they send them to us, and we take it from there. So it's that collaboration that is really is working wonders. It's really a good thing. There's always lack of trust in Cameroon, but once you're humble and you show people that you care about them, people trust you. And my experience has been positive. Maybe not everybody has been. We've had difficulties, but working with these ministries has been very helpful. And then also going out into the city, into the local quarters, and talking to people regularly. All these volunteers, they're all medical students, all really focus on trying to make a difference before they graduate college. So in addition to work with the ministry, of course, you got to work with churches, because a lot of women go to churches. A lot of our women, the women make up the largest percentage of churchgoers in Cameroon. So the volunteers went to churches in Cameroon. All this happened in the last 2 weeks. So everything I'm showing you guys is what happened in the month of October. Okay, we do this throughout the year, but for October, because it's breast cancer month, it's very important that these things get done, and it's making a difference significantly. People are coming up, they're talking, they're engaging, and we're seeing it impacting the communities. Also, I mean, nobody's left behind. The Presbyterian Church in Cameroon also, the volunteers go there, they teach women how to do clinical exams, teach them about healthy lifestyles, cut off smoking, drinking, and exercise, dieting, but more importantly, just know your breast. Know your breast. I mean, I think that's the best way. Know your breast. I'd also like to take a pause at this point and talk about some groups that we've worked with in the past quite a bit, and we'll continue to work with. They've been to the town hall before. Dare to Live Foundation with Willis and Foundation. We did a walk in Atlanta 2 weeks ago, and the goal was to raise money to help pay for people's cancer treatment diagnosis in Cameroon. And that walk was a huge success, and it's also part of that collaboration that we keep doing with people in both in the diaspora and in Cameroon. So that happened 2 weeks ago, and it was a huge success. So these are things that we're doing for awareness, both in the US and in Cameroon. You cannot do it by yourself. So now that we're done with awareness, let's talk about screening. Now, once you've told people that, okay, hey, here's what breast cancer is, here's what you need to look out for, where can they go to get screened? There are 4 tools to screen somebody with breast cancer. The self-breast exam, which I talked about already, clinical breast exam, which is done by a medical professional in a hospital setting or in a doctor's office, and then mammography, which is now available in the region. It wasn't just 2 years ago. And then, of course, breast ultrasound, which is a low-cost tool, but is very, very useful when it comes to diagnosing breast cancer or other benign breast conditions. So all these 4 tools are available right now at Claire, at the regional hospital, and these are tools that we're deploying. For women, when they come, our volunteers give them these little cards that they can take home after they've learned how to examine their breast, and they can keep in their purse at home, and they can use that to check their breast once a month. And we handed out 1,000 of these cards just today alone in Boya. 1,000 of these cards we handed out to people as we did our breast cancer awareness campaign. And of course, mammograms. There is one of my technologists at Claire. We have an active screening program. We have breast specialists, breast radiologists in Egypt and in Cameroon and the US that we consult with. It's a lot of work. It's not easy, but at least that tool is there right now in Cameroon, in Boya, to help people. And I'll tell you that we do our best to. It's not free, but we try. And I'll talk about the cost, how people can pay for it, and how we help people pay for it. But a lot of help comes from the US. But again, mammograms are available, and then of course breast ultrasounds also that are being done. Again, this is at Clay. This is at the hospital in Boya, where we don't turn anybody away. We do our best to not turn anybody away, because at the end of the day, we want to make sure that the society have an impact in the society. So we've talked about screening. Now that you've screened the patient and there's a suspicion, now what? Step 1 and step 2, that is where a lot of campaigns ended. After screening, the patients don't know what to do. They are frustrated. They are stressed out. They don't know where to go. But that's where we tell them that now there's a solution. And it's not just at Claire. There's diagnosis. You can go to Douala. You can go to Yaoundé. Even in Boya, the regional hospital is there. But we just want to be a place where people know that they have somebody that's listening to them that can actually offer them solutions. So for accurate diagnosis, obviously mammograms are super important, and breast ultrasounds are super important as far as imaging is concerned. Okay, that's diagnostic imaging. But to get true accurate diagnosis, you also need a biopsy and you need hormonal testing. Okay, that way you have a complete picture of what's happening. And then and obviously once you have a positive diagnosis, there are other things that you do with the CT scan to check for spread and stuff like that. But these are all available right now. And again, we don't offer biopsy services at the hospital, which is no problem at all, because guess what? We have partners who we work with. Hormonal testing, we have partners in Cameroon that we work with, that we send patients to. One of the trusted and approved by Dr. Muno is Centre Pasteur. I've received a lot of reports from them as early as just yesterday for biopsies. And sometimes when they come in, I'll call up Muno, we'll discuss it, and we give the patient recommendations where to go. But again, these tools are available. It's not just Santre Pastor, there are others, but we all know at least this one that I trust, Muno trust. I think we all know the good work they do. That's when it comes to biopsies. And so this is an actual patient from last week where fortunately the biopsy came back negative for breast cancer. Now, before I met this patient, they were not even thinking about going for a biopsy, but now they have that knowledge, and now they have something that we can go off of. There's other things that we're going to do with this patient before we continue with how we're going to manage our care. So now, once we have accurate diagnosis, now we got to go into management. How do we manage? What is Claire doing to manage these patients? Again, you have to tell people that if you have cancer, we can treat you. We have a way to. We have options. You're not alone. So just about 2 months ago, on the town hall, brilliant town hall. Everybody should come here every fortnight. We had Cameroon Oncology Center come online and share with us what they have to offer. And they are a premier delivery hospital for radiation therapy and chemotherapy, and I think also surgery. So I know Claire has quite a few patients right now at COC undergoing either chemo or radiation. So it's there. These tools are there. Once people know that these tools are there, then they feel like they have hope, right? And it's important that this knowledge gets put out. And that's what Claire is doing the whole of this month, letting people know that there's a treatment out there. When our volunteers go out to the clinics, to the community, to the radio, they tell people about COC, they tell people about surgical options, they tell people about accurate staging and accurate diagnosis. Again, triaging. I am going to talk about this so many times during this talk. Triaging is probably the most important thing because, again, we don't want to waste money on cases that don't have to be treated or cases that were not cancers to begin with. And for triaging, again, what Claire is doing, again, is working with professionals here in the US who we discuss cases and we always navigate. That's put information in the hands of people so that they can now go and we follow up with them. And I'm gonna talk about that. How we've been able to help patients navigate their treatment. Right now, I'm talking about like real-time data of people who are going through this process, and there are survivors who are going to talk about their stories and how their lives have changed and how they have hope, which I'm going to talk about a little bit. When people see that you're telling them something that is right, something that is true, and you can show them, you give them hope. You give them true hope, not false hope. Patients, doctors, families are beginning to trust us because not only do we have the staff and the equipment and the expertise, but we're also there for them. So they're beginning to trust what Claire is doing. And this model can be replicated everywhere in Cameroon, Douala, Yaoundé, anywhere. Okay? The key is to have people to trust what you're doing and give them hope, not false hope. Don't promise somebody. We're not going to make fake promises or promises that make them feel like, okay, not everything is fine. No, cancer is serious. It's a serious disease. Let's not get it wrong. But breast cancer is curable. So when you tell somebody that you can get that they can be accurately diagnosed, you tell them that they can get evidence-based treatment, surgery. For example, if you get surgery, you need radiation therapy, which is now available in Douala. And you tell them about this, all the surgical interventions that are available. Hormonal testing is available. It's inexpensive. We talked about this 2 weeks ago at the town hall, and the many hospitals that offer hormonal medication for very, very inexpensive. And then, of course, chemo is also readily available. Let these people know that these options are there because breast cancer is actually curable. As a result, like I said, people are beginning to take your test results serious because they now know they have an option. They now know they have a chance. They can fight. That's what we want, people to know that they have an option. And some of this evidence might be anecdotal at this point. We're still compiling the data, but I'll tell you, this is real-time data. This is what I'm seeing on the ground, and this is what keeps us moving, keeps us going. So another thing that has changed is that not only are we giving hope to the patients, to the clients, but we are also changing the way doctors in Cameroon are practicing. Now we're hearing doctors asking about the hormonal status, which 5 years ago, most doctors wouldn't really care about hormonal status. doctors are now asking about CT scans to ensure that the breast cancer hasn't spread, because we know breast cancer can easily spread to the bones, to the brain. So a full CT scan is important. The chest, abdomen, pelvis CT. And doctors are now asking about biopsies. Hey, get me a biopsy. The patient I was talking about yesterday had a biopsy, and the biopsy came back negative. So that was a good thing. So we are seeing a change in Cameroon how cancer is being diagnosed and treated by the local doctors, which is the end game, right? Because the local doctors are the ones who are going to be there to actually do this, perform these treatments, not us from America. We're not going to parachute in and make the difference. We have to empower the people on the ground. But also very importantly, we're also making it, people are spending less money because we have the triaging solutions. I'll give you an example of a patient just a few days ago who was told to go and do an MRI with possible prostate cancer. Well, an MRI is not what you do from just because your PSA is high. There are so many things that you got to do first. And MRIs by themselves, MRIs for prostate are usually very hard to read. In my practice, we do MRI prostates only when it's time to treat the patient, when we want to maybe give a very high dose to a certain part of the prostate. So it makes no sense to have a man who's a farmer somewhere and making $50 a month, and they should spend $100 to get an MRI for prostate cancer when that MRI is not beneficial to them at that time. So there are other things that we're doing. So we're not only saving people money, but it's also standard of care, right? You don't just get an MRI done. Even here in the US, that's not the first thing we'll do. And then, of course, there's less delay in starting care. Again, those are things that we are seeing with people in Cameroon, especially young women. I'll take a pause here and just really talk about what is happening in Cameroon when it comes to young women. They're so I'm just really surprised by the number of women in their late 20s who are being diagnosed with breast cancer, and that's something that we all have to pay attention to. So some things what is CLARE doing? CLARE, and when I say CLARE, I'm talking about these umbrella organizations that we're all under, right? There are many of us that are working together. We're trying to be different, okay? I mentioned we have a comprehensive breast cancer solution. And something that we're also doing is that we're trying to lower the barrier to breast cancer care, all right? A grandma who is there is suffering, maybe has a lump in her breast. Sometimes they can't even come to the clinic, all right? So we try to find ways to go and pick them up, all right? And then when we pick them up, when they come to the clinic, we try to subsidize their scans via donors. We have a lot of donors in the US. In fact, 90% of our donors are in the US. And I'll say 20, 30, 40% are from the town hall who are contributing every day to pay for people's people's scans. We try not to completely subsidize anybody's scan, but we try to make sure that the payments are based on affordability through either our foundation or through, like I said, donors here in the US. Something we're doing differently is follow up, and I'll talk a little bit about that too some more. It's very, very important. Following up patients. The doctor should do it. The staff should do it. We are doing it at CLARE, and I'll show you how that's making a difference. And then one thing we're doing at CLARE also, we are targeting the high-risk population, and I already talked about it, where we're using the Ministry of Women's Affairs to show us, to kind of guide some patients to us, because they have their tentacles are stretched wider. So we can target that high-risk population. We're not just doing random screening. It's important. Again, the resources are limited. So those are some things that CLARE is doing differently that is making a difference. And as a reminder, why are we doing all of this, right? Number one, we want to reduce mortality, okay? Deaths from cancer. Like I said, breast cancer is very curable. And then, of course, we want to reduce the suffering. It's not just about dying, but it's about suffering. When the mom is suffering, the family suffers. So we want to reduce that suffering by diagnosing early so we can treat them, and then they don't suffer from pain and malaise and just overall cancer burden. And then I'll mention about the intent. Are we trying to cure this patient, or are we trying to do palliative treatment? All those things matter when we are talking about breast cancer in particular. Again, this is super, super, super important to understand when to treat and when not to treat. What lessons have we learned? One thing that we learned very fast is that once we started talking to the local doctors in Cameroon, patients listened, and there was buy-in. There was a significant integration between CLARE, all the local partners, and the local doctors. And I mentioned this at my last talk here in February when I came to the town hall. I mentioned something about doctors taking advantage. When patients come in, talk to them about breast cancer. Tell them to go get a scan, get a mammography done. And now it's available right there around them. They don't have to travel far. So my call to the doctors here is that we've seen the impact of when my assistant in Cameroon goes and talks to doctors to talk to the patients. And sometimes he'll go to Mutengene, and within the next 1, 2, 3 weeks, you see an increase in the number of patients from Mutengene because the doctors are talking to the patients. So you guys have a big role. This is really, really important. It makes a big difference, and it works. And then one thing that we do is that when we do it, so this is an actual mammogram report from Claire. What we do is we try to also, no, we don't try, we actually do it. That every report has a clear recommendation. And then we follow up. Once the patient leaves the clinic, a week later, we try to call them and say, hey, they see me can do ultrasound. When are you coming for it? Stuff like that. That too is making a big difference. It's making a big difference. Like this is a case where this was I think this patient needed an ultrasound for lymph nodes that were suspicious. Ultrasound is really very important for breast cancer diagnosis because ultrasound can easily determine whether it's a tumor or it's just a fluid-filled mass. So ultrasound is super critical. It's inexpensive. So it's something that will be done when the radiologist calls for it. This is another one where I think it was normal, and all they do is they tell them to come for the annual mammograms. So when people have to come back for follow-up tests on ultrasound, something that we're working on at Claire right now is to find a way in which if you come for a mammogram and you need an ultrasound, when you come back for that ultrasound, it should cost significantly less, right? Because it's still part of your management. So we're still working on that to try to see how we can structure that so that people don't. There's nothing worse than coming for a mammogram and there's a concern and the patient goes and never comes back for the follow-up. That's worse. So we have to find ways to encourage that patient to come back to Claire or to come back to any hospital that does breast cancer screening or advanced testing, because that is how you actually get to an accurate diagnosis and then you get treated. So hopefully that's going to make a difference in the next future. It's not been all roses, I'll tell you that. We face significant obstacles. My goal today is not to talk about the obstacles, it's to talk about the successes and the things that are working. But we face significant obstacles, and we know we still have a lot of huge challenges coming up. There's still a lot of misinformation. One thing that a question I get all the time, well, I get it enough, that mammograms themselves cause breast cancer. On the face of it, it sounds true. Well, okay, it's radiation, but no, it's false. Mammograms do not cause breast cancer because the amount of radiation that is given to the breast during the mammogram is so small. It's very small that the probability of it actually causing cancer for the mammogram is nil. You get, just by walking around, you get as much radiation in 2 months as a woman gets when she does a mammogram. So all of us here in this town hall, by the end of this year, which is 12 months, we would have all received an equivalent of 6 mammograms. Okay, so women should not be afraid about getting a mammogram that is going to cause them cancer, because the science just does not that doesn't follow the science. It's false. But these are some things that again, the doctors can talk to the patients about to put them at ease. And then of course, we've been very fortunate again with buy-in from the government resources. So, like I mentioned, the women's Ministry of Women's Affairs. She's actually been to the clinic, and we've had discussions with her. But also the regional delegate, who played a big role in the big campaign that we did today, which I'll talk about here in a few minutes. But also all the local hospitals that are there. It's all hands on deck. It's all hands on deck, and I just cannot be more grateful for what we're doing. So it's being October, so we have to talk about what happened. So we did a walk with all these partners, and again, remember why do we do walks? This initiative was focused on raising awareness. We all know that, and to promote early detection and to encourage the community to be involved in breast cancer. So this walk actually ended probably 5 hours ago, and obviously we had the ministry, the MTN, and a bunch of other partners, University of the Medical College students, students union, students association, and just a lot of people who all came together. And a lot of the students, Dr. Tambi has been always trying to get the students to come to the town hall, and those students showed up big time to help out in this screening event. This is just a cross section of some of the people that Claire works with, and the organizations that not-for-profit organizations. These are two of my young doctors in Cameroon who are out there every day, going into the villages, going into the inner cities, and talking to people about breast cancer, and just really making an impact. So this is I think this is when they were about to start the walk. This is somewhere in Boya, in Moliko. It's a coalition, pretty much. They're all happy and just really I'm glad to be there. And then obviously there are other humanitarian organizations were also part of it, and even secondary school kids also came to support their parents. So yeah, it was just it really gives you that satisfaction when you see stuff like this. There were over 650 people showed up today for that walk, and this number reflects not only the community's commitment to raising awareness, but it also highlights the effectiveness of the outreach efforts. So when we talk to people, go out and talk to people, then they come out. So it's showing that it's working. It is working. I'm going to end by talking about this survivor. She's 30 years old, Miss Asu Cecilia. She's 2 years past her diagnosis, and she gave a talk about her story and how much the sensitization, the awareness, and just being happy that she was lucky to have found her cancer early. Again, I mentioned there are so many people in their late 20s, early 30s with breast cancer, and it's curable. There are people in America with stage 3 breast cancer, stage 2, who are living normal lives. So, and she's 30 years old. She's still got a whole life ahead of her. So anything that we can do for people like this is really important. And I think this town hall is really doing a good job in putting the word out there. So what is the way forward? We're going to double down on breast cancer awareness. We're going to double down. It's a low-hanging fruit. We can really make a difference. Give your time, give your finances, give your expertise, because breast cancer is one cancer that we can beat down. Absolutely. So join the fight. Thank you very much.
Wow. Thank you very much, Sidney, for this amazing presentation. You can stop sharing your screen. Thank you so much for your informative and impactful session. It's really been great. Your insights really are important, and I've shared, some of the challenges we face in combating this disease, but also the progress that has been made to raise awareness and improve access to care. So it's really been great. Your commitment to share this vital information has really been inspiring, and just the approach in which you've used to do this presentation. While the statistics and the realities might be sobering, but I see you shine a light of hope, that with continuous effort like yours, we can make a difference. That through early detection, better education, increased access to treatment, we can reduce the burden of this curable disease in Cameroon. Matt, how did you see the presentation?
I think it was a wonderful presentation, especially the role. C'était une belle présentation, particulièrement le rôle de la communauté pour rendre cette cause visible. J'ai beaucoup apprécié aussi à la fin la survivante de cancer qui était âgée de 30 ans. Ça nous rappelle que ce n'est pas, je pense qu'en Amérique, on parle toujours des patients de 50 ans et plus pour le dépistage, mais en Afrique, on peut peut-être penser que l'incidence arrive beaucoup plus tôt. Donc, des patients de 30 ans, c'est quand même des patients très jeunes. Alors, c'est sûr que c'est quelque chose qui nous touche particulièrement parce que c'est une patiente qui est dans notre région. J'ai beaucoup de questions et je vois aussi qu'il y a une question qui rallie ma question dans le chat. Je ne sais pas si on veut passer la main d'abord à Dr. Mono pour un commentaire avant qu'on passe à la période de questions.
Wow, thank you very much, Sandrine, and thank you Sidney, you never disappoint. So as I always say, Sidney is one of the shining stars in Cameroon that gives us hope and gives the diaspora hope that we should stop really asking ourselves what our nation has done for us and start asking the same question, what have we done for our nation? I think that's the time for us to start changing things. And when JFK said that, he meant it. And it led to a lot of revolutionization. And I think that's how we should look ourselves. One of my patients told me yesterday that breast cancer changes you and the change can be beautiful. The reason she told me that is that it made her perspective about cancer did change, and she's become an advocate for women and an advocate for access to healthcare. And also she had to even change her political affiliation as a result of that because she saw that things were not done the right way. So she just told me that out of the passing. And once you can never be as strong as a cancer patient who has survived because there is just so much fear. I see about 25 of them every day in my practice. I get to discuss with them. I don't know exactly if I'll ever be as strong as them, but this is an eye opener. And as Sandrine and Sidney said before, here in the US, 98% of all my breast cancer patients get a cure. That's the truth because they have access to diagnosis, not only in the US and in Europe, most of also Asia now. They have access to early diagnosis. We screen a lot of them and we diagnose them early and we treat them early. Now, how do we transition that over to Cameroon? How do we get ourselves to the point where we understand that that is going to help us? So I think we'll have a wonderful discussion. I see a lot of hands up. And yeah, I don't want to use time today to spend time talking about treatment, which we will talk about that in 2 weeks. And I can answer questions when it comes to treatment if others want for us to get into the details about treatment. But I think I want to give time for us to really have a wonderful discussion and how we can do as a group, those in Cameroon, first and foremost, and those in the diaspora, how we can do as a group in order to sensitize women for breast cancer. And the mother is usually the gateway of health. I don't want to always put it that way, but that's true. The woman cares more about health. And if we use a female cancer like breast and cervical cancer sensitization, we'll get other cancers to get traction. And we'll get healthcare to get traction overall. So thank you very much. And thank you for what you're doing. A lot of this is just the tip of the iceberg for those who don't know you. It's the tip of the iceberg of what you do in Cameroon. So, and we came today to talk about breast cancer, not really to talk about Claire, but you're doing a wonderful job in Cameroon and continue the wonderful things you're doing. You make us believe.
Thank you so much, Chair. And we have our co-moderator, Brian. Dr. Brian is in the house. Hello, Brian.
No, thanks a lot, Elvis. It's great to have you. I thought it was a really insightful presentation. I love the emphasis on community engagement, as Dr. Matt highlighted as well. So it was really great. And congrats for the great work you're doing, Dr. Sidney Tazeh. Over.
Yes, great. Before I hand over to Dr. Sandrine to moderate the question and answer session, I want to just recognize Professor Shewi Songa, who is in the house. Hello, Prof. It's always a pleasure to see you.
Thank you.
Prof has been with us from the very first day, and whenever he has time, he finds time to join us. So thank you for always coming on board. I'll hand over to Dr. Sandrine to moderate the question and answer session.
Thank you, Elvis.
Your question brief, and please just always indicate where you are asking your question from so we can get a sense of the places where you are dialing from today.
I think we'll take the first question in the chat before we go with anyone else. There is a question in French. La question en français, c'est de savoir justement qu'au Cameroun, on a de plus en plus de femmes jeunes qui sont diagnostiquées. Et la question est de savoir comment est-ce qu'on peut rendre les tests génétiques accessibles aux femmes à risque. À la toute fin de la présentation, on a parlé d'une survivante. Ma question, c'est de savoir aussi, est-ce que les membres de la famille ont été, est-ce qu'on leur a offert un test génétique pour savoir s'il y a des mutations dans les gènes BRCA1, BRCA1 et autres gènes reliés au cancer? So the question is about how can we make accessible genetic testing for high-risk women, particularly women who have been diagnosed or have survived the cancer. Is there a way to make available those tests for the family?
Okay, I can help take that one a little bit. So Sidney, maybe you can add your mute.
Yeah. Mundo, go ahead. You can go ahead and answer the question.
Yeah. So for genetic, in Cameroon, I did a little bit of clinical pathology, but we do have issues with access to genetic testing. And Kenji did a presentation here. I think that was like a month ago, exactly 4 weeks ago, talking about how we can get access to doing genetic testing in Cameroon. We have a lot of the equipment already available, and we have the platform, as we would say. But offering those tests is very rare right now, still very rare, especially for cancer screening. There are areas where you can get it, which most of them are done abroad. They are quite expensive, but the question is, are we offering it? Right now, for guidelines, it used to be for high-risk patients to get genetic testing, which what we define as high, but it's changed. So the US just changed the guidelines. Every patient with breast cancer gets genetic testing if they want to. But at first, it used to be younger than 40, triple negative, coming from Ashkenazi Jews, certain groups of population, if you have family members with that, but everyone. Now in Cameroon, how are we going to change this? We need investment. We need to realize that we have a demographic which is a bit different. I'll tell you a story. There are Cameroonians that I have worked with who have had breast cancer, not that I've worked with, I've gone through their case. Some of them are family members, some of them are friends. I was very shocked with the amount of positive Lynch syndrome, not even BRCA1 and 2. Positive Lynch syndrome, I was shocked. I was shocked with the amount of Lee-Frattini syndrome that was actually available. Those were coming out positive in these groups of people. You also do have a certain group of population in West and Central Africa which are highly BRCA2 positive. So we can never, statistics is where we start, so we need to build that platform. We need to talk with people like Kenji. We need to talk with M.Sc biologists back home. I see some of them here. I've seen Sharon is here. Bacham Sharon, she's here. If I may, so what are they doing? What can we do? How can we use the platforms that we have in place in order to get ourselves access to this kind of testing and make it affordable too? Because it's not just getting access to it. You don't need an NGS to be able to run that, though you can easily do that with an NGS. But how do we make it accessible, affordable, and get the diaspora to invest in it? I think Sidney will tell you he has that in a platform coming. That was the next platform. So Sidney, over to you to talk a little bit. And I would say we don't really understand the demographics very well about the disease in Africa because a lot of the research was done in the West. And as much as we don't study ourselves, we'll never really understand. And there are other genes that we don't know. There are some things we call VUSs, which are genes that are mutated, but we don't have enough data to tell what they really mean. And Africa is the birthplace of humanity. We have the highest variation in genetic variants within Africans themselves. West Africans are not the same as East Africans, neither are they the same as South Africans. There is a lot of genetic variation in Africa. So we need to really study the African population to understand what is happening, really, what is going on.
Yeah, absolutely, Dr. Mono. So genetic testing is definitely, it's one of those major obstacles that unfortunately the sad news is that it's not something that we are going to come around anytime soon. But something like hormonal testing in the US takes a few days, right? And then genetic testing takes, I don't know, 3 weeks, 1 month, 6 weeks. That's in the US. Now imagine how long that would take if you have to do it in Cameroon. And then now talking about, okay, the anxiety, you're waiting. So personally, it's it's a wish list for me. We have access to it here in the US, but in Cameroon, if somebody asks me about it, I'll tell them, hey, it's not going to come in anytime soon. For those who can afford it, they can travel, they can get the samples and send it off. But I will not wait up for it. To be honest, that's just my yes. From a practical standpoint, when there's just a lot before we get to that point in Cameroon where we can be able to offer genetic testing on the grand scale, like just lack of data by itself in terms of the genetic makeup of Cameroon it's not even available. So I try to worry about problems that I can actually solve, and things that I cannot solve, we talk about it and then I move on.
So I want to ask, maybe I don't want to put her on the spot.
I just want to add something.
Yeah. So let me ask, I just want to ask Sharon Bacham, who is here, if she wants to unmute herself. If they do have, I know we send this test a lot out to France and other things. She's a clinical pathologist in Cameroon that I know very well. And she was my young colleague. I want to know if right now, are there any things in place in Cameroon, in Centre Pasteur? Her father runs one of the biggest labs that we know about in Cameroon, which has been very helpful in our training. Is there anything in the pipeline concerning that?
Hello, thank you, Dr. Mono, for giving me the floor. Actually, you rightly said most of these tests are actually sent out, but more and more, I think a place like Central Pasteur is trying to also, I think they have in view of bringing this test here because, I mean, it becomes cumbersome, and most of the times the oncologists kind of, go ahead with medications because when they think about the time frame of sending it abroad and waiting and the costs involved, they feel like, okay, because we have symptoms that, the signs, what we see, that can actually, attest to the fact that we can give so and so medications. Okay, they go ahead, but if those patients are able to afford it, because it's all about affordability as well. If they're able to afford it, then they can actually, but more and more, honestly, they still me.
Yeah, thank you very much.
So more and more, it's I think they're bringing it, and on my part, I have always been, always questioned myself. We have the manpower, we have the intelligence to be able to do these things here on site, and it's one of the projects we have as well in view, with my dad as well. So to bring those kind of things accessible and affordable to people around. Yeah, in Cameroon. Sorry.
Thank you very much, Sharon. Thanks for joining, and we'll be inviting you one day in the town hall to share with us what you guys are doing, okay? Over to you, Cedric. Sorry.
Thank you. I just want to make a comment that genetic testing is now available in Ghana. There's a former J&J R&D chair from J&J who has opened a laboratory ISO certified for genetic testing in Ghana for breast cancer and other cancers as well. So over to whoever wants to has a question. I don't see the hands raised.
My hand is raised up.
Okay, Franklin Maloba.
Yeah. Good morning again, the Tango, and good afternoon to those in West and also those in Cameroon. Good evening. Yeah, I wish to thank Cindy, Dr. Mono, and the Tango team for really taking this topic as something very important, especially to our suffering population back home who are not aware of this. I wish to also thank Cindy with his clear team. I wish to thank the cooperation of the minister, other organization. I think this is the way forward to say that Cameroon is really moving forward. Yeah, going back to Dr. Mono's point that we should not ask what the country have done to us, we should ask what we have done to the country. I would say no. I think sometimes it's good to hold the country responsible too, to know what the country has done for us. For instance, Cindy is from the diaspora, Dr. Mono is here from the diaspora, nobody pays them, they are here. what has the country done to encourage many people to come back home? Give them dual nationality so that they can have confidence in what they are doing back home. They can have control of their projects. And we encourage a lot of Cameroonians to take many initiatives back home. It's high time we hold the country accountable too by putting the square box in the square hole. Thank you for that. So, Cindy, I think it's a good point that you're doing. So, according to the Business of Cameroon and Cameroon Intelligence Report, more than 10 million Cameroonians are living on the poverty line. That's less than $1.8 or $1,000 a day. And that's 1/3 of the population. And many of these people that even have this breast cancer are living in rural area, these women. And being even aware that they have this cancer is already a trauma for the whole family. So to you, what can you tell these women when they have cancer? What should they do? Secondly, how much will it cost, the estimate, if they have cancer, what will it cost them to treat this cancer completely? So that they will plan better for the family not to stress with the poverty that they're already facing. Thank you.
Yes, thanks, Mr. Allen, for that question. Before I started Claire, I used to take almost a unilateral one-man army, try to do it by myself in helping to pay for people's scans, people's treatments, but that just wasn't sustainable, right? I mean, how many people can you pay for? But since Claire has been in existence, what I'll tell you is that the amount of people who volunteer to sponsor either scans or even treatments, that number is steadily going up. I'm not going to pretend that we are going to be able to fund everybody who cannot afford it. But what I can tell you categorically is that we've not turned away a single patient at Claire who's come for a testing service. We've not. We have a foundation that we try to raise money outside. I mean, personal funds, people like Dr. Mono and others in America who contribute regularly. So come forward. That's what I'll tell that mom, because I think it's worse if she comes to you and you're dismissive or you don't come forward. Personally, Sidney, if an old woman told me that she had cancer, I would not. I'll find some money for myself and try to help that person. But as a long-term goal, that's why Claire is trying to get the community together, because I cannot do it by myself. So there's treatment out there. I'll tell them that mama, there's treatment out there. COC was the CEO of COC was here about 2 months ago and did mention that at COC payment is being made on a sliding scale, and I ended up with a fact because I had a patient. I don't want to say exactly how much, but the initial amount based on the cost for the treatment was a certain amount. But after she's 24 years old, 26 years old with lung cancer. But after she presented her case, the cost for treatment dropped significantly to less than half of what was being offered. Was initially asking of her. So just like the same thing we're doing too, we're trying to do it on a sliding scale. Fortunately, so far we've been able to handle the load that we're getting. Who knows tomorrow? I can't tell you if 100 people show up and they don't have the money to pay for it. That'll be rough. But we'll cross that bridge when we get there. So I'll tell that mama that there's hope. There's hope. And Sidney, send that to me.
Yeah, my point is, Cindy, is it like, let me see, if somebody have an early breast cancer, will you say the estimated cost to treat that is like $1 million? Because I was happy you gave the hope that it is treatable and curable or curable. That is a very positive thing that I took out today, and many of these patients will have hope. But the point is, the price, as I mentioned about the poverty line in Cameroon, what will you tell them? Will it be less than $1 million? Will it be like 2 million, so that they can know if they sell their one plot, they can treat their mother or their sister, But we are talking the reality on the fee. I would want to sell my house if I know my sister can be treated for 2 million.
Yeah.
But if I know that after the 2 million, we cannot treat her, it means that we will remain poverty, we increase the poverty in the family, we'll just manage it traditionally or other means. Absolutely. So the question is, when is that fine line? Estimate. That's what I'm asking.
Well,
so that those outside there who watch this video will know that, okay, we can say this plot, maybe 1 million, we can cure this cancer, which is stage 1. This stage 2 can cost 2 million. Stage 3 can cost 10 million, so that they can have hope to reduce their poverty. That's what I'm asking. Thank you.
Yeah.
If I may, Sidney,
answer a few questions here, but and Sidney has gone to the, as I said in the beginning, we cannot estimate the cost of something when you have not staged them. We need to, you can't just tell them, okay, stage 4 is breast cancer is complicated. Sidney told you, it depends on, breast cancer is a very complicated field. It's just like telling me, no one even in Cameroon tells you that when you have high blood pressure, this is how much you're going to spend. But we do know that if it's diagnosed early, then Dr. Umbaku, maybe in the regional hospital in Bamenda, can offer you surgery early and can actually subsidize your surgery. The doctor in Bingo can offer you surgery, and the price in the government hospital is different from the price in the private hospital, but it's going to be less than 100,000 usually just for the surgery. I'm just giving you an example. The doctor at Bingo, the last time we were here, and I work with them all the time, they told you that once we're doing hormonal testing, if they are getting hormonal testing for you to be done, which is like a baseline, Sidney and I, we have been campaigning for this for the past 5 years, and it's getting traction. Baseline from Bingo is 80,000, if I can remember well. That's what he said, that they can get it done in the US for 80,000. Central Pasteur does it too for about 150,000 or so. So these are all things that are important. And not everyone even needs scans. Not everyone needs a CT, chest, abdomen, pelvis. If you have a very small nodule, you may not even need that. So it's very heterogeneous in itself. And most of the time, I would say screen early, go see your doctors. We're training the young doctors now. I'm going to give a lecture in 1 week, what to do. The doctors will be able to estimate the price, but I'll tell you, if you have early stage breast cancer in Cameroon, your treatment overall could be, I'm not using the word because it gets very complicated of how far do we want to go? Your treatment could be less than 500,000 if you're taken early, but it now depends. If you come in and you are now triple negative, that makes things complicated. So all of this is a very complicated, your question is very valid, but it's like a healthcare question, like how much do we treat any disease you want to say, which breast cancer in itself, it's a complication of multiple diseases in one that we are just calling breast cancer, but it's a lot of things. If I want to give a frank answer, it's going to be difficult, but earlier we diagnose these women, the better we're going to treat them, the cheaper it's going to be for the family, and they will live longer. I think Sandrine had something to add too.
Yeah, I think you actually said it very, very well. I just wanted to ask a question, a follow-up questions to what Dr. Mono just said. The earlier we diagnose them, we screen them, they have a better chance of living a healthier life after. But I think most of the women in Cameroon are diagnosed at late stage. So, la plupart des femmes au Cameroun sont, en fait, ils ont un dépistage quand ils ont déjà un stage avancé. Alors, pour être pratique, parce que la présentation se veut aussi très pratique, qu'est-ce qu'on fait pour ces femmes-là? C'est bien la campagne de sensibilisation, ça touche celles qui ne sont pas nécessairement encore dans un cheminement de prise en charge. Alors, qu'est-ce qu'on fait concrètement? Qu'est-ce que Clear ou les autres centres, je vois des médecins ici, je vois Dr. Mwele qui est en ligne et puis d'autres médecins aussi, Dr. Shoshua Tambe, qui sont en ligne et qui parlent de la prise en charge des cancers à l'hôpital général de Yaoundé, l'hôpital central. Qu'est-ce qui est fait concrètement pour ces femmes-là qui sont en stage avancé? Et est-ce que la question, la réponse, le titre qui a été amené aujourd'hui, que le cancer est guérissable, est-ce que c'est guérissable pour ces femmes qui sont en stage avancé? Quand on sait qu'au Cameroun, la plupart des femmes qui vont venir se faire dépister, c'est au stage avancé, c'est pas au stage précoce.
Yeah, excellent question. I'll take that a little bit and allow Sidney. Sidney, you want to take it?
Well, yes, I'll just add real quick. Yeah, so I think Dr. Mono is right in terms of the ballpark, right? It's impossible to give a number, but if you ask me about a specific case, I could look at my records. I just looked at one record right now. It was under 500,000, that's for sure. And this was lung cancer, which is a little bit even harder to treat. But it was under 500,000 for the treatment. But one important thing to note is that even for those who can afford it, one thing that's happening in Cameroon over the past 5, 10, 20 years is that those who can afford it, they end up going to India. And guess what happens a lot of times? Because it's diagnosed late, they go to India and they end up losing the battle in India. And they have to now repatriate the cops. Then it costs more. Or I'll tell you, having been in this field for 18 years, that the care that they're going to receive in India is not that significantly better than the care they could receive in Cameroon. Now, they're obviously state-of-the-art clinics in India, don't get me wrong. But how many of them are actually going to those high-end hospitals? Let's face it. So what is happening is that now some of these treatment options are now available closer to home for significantly less than buying a flight, paying a hotel. And cancer treatment is a long-term thing. I will hardly ever encourage somebody to go and get cancer treatment abroad unless you are wealthy, rich, because it takes weeks and weeks for radiation. It takes weeks for chemo. Whatever you do, you're going to be out there for weeks, and it's going to cost you a fortune. So if you diagnose it early, my recommendation, I've been on the ground and been practicing, is that try to get your treatment as close to where you are. The support that you get for your cancer treatment is almost as important as the treatment itself. That's something that we don't talk about a lot. All right. When you go out there in India or somewhere else, you don't have a family around you, that can take a toll on you. But if you can get that treatment closer to home, then it's gonna not only is it gonna save you money, but also you're also gonna fare better because you have that support system that carries you through treatment. So there's some things that you should definitely take into consideration when you're trying to weigh cost. But yeah, there's no straight answer on there's no catalog for cost for therapy for cancer, for breast cancer.
And just to add to your second question, Sandrine, this is to me, I put up this presentation because it's super important. This is like the ABC of cancer, breast. I call it the ABC because, I've hammered this for so long. And I've hammered it to even our medical oncologists back home, because back 5 years ago, I had a series of cases where this basic data was not available. So for the case that you presented, those who present in Cameroon with advanced cancers, the first thing they should do is get the most reliable biopsy source. I prefer Central Pasteur, and I will tell you, I've told Sidney that over and over. I prefer Central Pasteur to get your biopsies analyzed there, but you can do it anywhere, which is Bingo sends it. They have an in-house pathologist and they send their samples to the US. Now, every breast cancer patient, if they have their last 100,000, you should use it to know the ER, PR, and HER2 status. If it's the last 100,000, Dr. Iran is going to tell you he's here. We were very shocked with many cases. They should use it to know this. Metastatic disease, don't spend time giving people treatment that is not going to work. This is my take-home message, even to those who are Cameroon. They'll tell us what they're doing, but this is what they should do. Every woman who comes in with an advanced stage, who is a stage 4, who has metastatic disease, does not benefit from surgery. That has been proven. Surgery is not beneficial. If you're doing surgery, it should be for palliative reasons. And surgery should not be your go-to. Second, you should know their hormonal status before you move up to do anything based on that. Once you know their hormonal status, as we say in oncology, all stage 4 patients are not curable at the moment for breast. But every stage 4 patient is not the same. Those with triple negative breast cancer are not the same as those who have HER2 positive breast cancer, and they're not the same as those who have hormone positive breast cancer. That takes me to this slide. These are the 2 slides I always want to share. This, I just got it from my presentation. I just wanted to show this. This is very important because treatment is going to be based on this. If a patient actually who comes to see you in Cameroon, if you don't know this, how do you treat them if they are metastatic? It just tells you you're doing the wrong thing. If a patient ends up, and the truth about it is that 70% of our patients are here on this slide here, where only by giving them anastrozole, Sidney will tell you there are many patients, my friend Erwan will tell you, we have just given patients hormonal treatment, their cancer has healed. without any problem because we knew their hormonal status. Even they could not afford chemotherapy and they did not even need chemotherapy. A lot of them do not need it in the metastatic setting if they don't have a visceral disease. So you need to know this in order to even talk to them about their prognosis, because a lot of women who are just endocrine therapy, they may live for another 5 to 10 years before you even change treatment. Which may be a different thing from those who are triple negative patients, where we don't even have access to immunotherapy. HER2-directed therapy is like 500,000 for a dose. That becomes complicated, and the discussion is more difficult to have. So your question is very practical. I would love to hear the input for those who are back in Cameroon who are doing this. I've been partnering with a lot of people doing this, but I would love to hear those who are doing this, how they approach it. But I think the last Cameroon Society of Oncology, their term last year, and it took place after the breast cancer month, was for all breast cancer patients to get immunohistochemistry. And I think that's still supposed to be the emphasis.
Thank you, Dr. Mono. I think Dr. Michel Muele has something to say, a follow-up. Dr. Muele. I don't know if your audio, you're probably on mute. Vous êtes peut-être en sourdine, Dr. Michel Muele, si vous voulez ajouter quelque chose.
Et Dr. Muele peut parler en français, s'il vous plaît.
OK, peut-être qu'il va se mettre enlever son micro qui est en sourdine. Dr. Muele, est-ce que vous nous entendez? OK. On va continuer avec une autre question.
While waiting for Dr. Mwele, we have realized that in Cameroon, a lot of cases in breast cancer are being detected when they are already advanced. Yeah, why? I don't know if there are any studies to know about this. Because personally, to me, maybe these guys, they are even aware, but because they just know that it is something that, they feed the noodles, they just say, oh, maybe I can cope with it, this poverty line. So Cindy, with your experience, what should Cameroon do to really avoid that this patient come to the hospital in the advanced level? Yeah, because I think awareness has been there, but we still face a lot of these still coming in the advanced level. What then should be done different to really attract this patient early to the hospital? And also, Dr. Mono mentioned about that he has actually realized that there's a lot of linkage coordinate in this cancer to different families. So based on that experience, Dr. Mono, with your huge experience, which means that the prevalence or the incidence is really high back home, what should be done by the ministry to really make sure that we avoid this patient even reaching these levels? Thank you.
Yeah, Mr. Franklin, thanks for those questions. So the honest, straight forward answer is the only one-way ticket to the type of curative impact that we desire in Cameroon is early diagnosis. I think that's pretty much the only way we can get ahead of this disease, because we do not have the type of treatments that America has. People with stage 3 cancer in America are going to get treated and they could still live a normal life. They could have a survival of, I don't know exactly the percentage, it's still very high. But in Cameroon, we do not have that. I mean, like, if somebody has surgery, usually they recommend surgery and radiation. Not many people are going to be able to afford both of them. So what that does is that if you get surgery and no radiation, then it reduces your overall survival. So, but the best way is catch it early so you can go there and remove that little lump that is there, and then your survival is the highest that it can be. So there's no way around it except sensitizing and sensitizing. That is a mountain we're going to die on, because we're not going to treat our way out of cancer in Cameroon. Not now, not in the next 10 years. We're not going to treat our way out of it. We have to sensitize prevention and early diagnosis so that we can. Surgery is available. It's readily available in Cameroon. So that's a tool that we know is in our toolbox. That complex combination of chemo, hormonal, immuno, and all of those, it's not everybody can afford that. So we just have to double down and let people know your breast, get screened. Early screening saves lives. The organizations that we're working with, they go out and they talk to women about know your breast. We've worked with Hero. Hero in Cameroon is one of the people that we've worked with continuously. And they have people, they have young doctors out there doing just that. That's the best thing we can do for ourselves. Let people know, let people on, get yourself checked at home. And you can get treated and live almost a normal life. That's the only ticket.
Yeah, so the second part of the question, I will say that, Maloba, as I said, if you cannot study a population, you can't really have data on what is happening. What I'm seeing is observation from immigrants who love Cameroon and other parts, where you see these other genes that they could be rare, but they are available in our population, our young girls who have had breast cancer and others who have had other cancers, including prostate cancer, that we need to know about. As I told you, Lee Framini gene, there are patients who have CHEK2 genes that we are identifying. And Sidney set it up. Prevention is better than cure. If we cannot do screening from 40 years and do mammograms every year, we should use a WHO standard, where we get screening at least at the age of 50. Every woman, it should be available in all hospitals. The minister has done an effort. I will tell you that. There's mammogram now in every region, I think so, in Cameroon.
That's correct.
There is a mammogram in every region, and that has been going on because we've been in communication with the minister about this topic for the past 5 years. There is a mammogram now in every region, and we should put in place, every general practitioner should know that WHO recommends you, every woman 50 years and above, that's part of being a general practitioner, to do a mammogram every 2 years. And if it's done in a government hospital, it's subsidized. Rather than doing, when everyone comes, you do a Vidal, do a malaria test, Vidal that doesn't have any use, they will spend about 3,000 to go do Vidal. And then you're doing all these tests, making the labs rich when the results don't really matter. These primary doctors need to change their mind frame and know that women need screening for cervical cancer. They need screening for breast cancer. It's available in all the 10 regions. It's available in the private sector. They should get those things done. Once you do that, you catch cancer early and you'll be able to offer them treatment which is affordable, and you'll be able to also prolong their life expectancy. So that's the way I look at it. But when it comes to genetics, we are far away from that. We need a lot of investment in order to get to that part.
Yeah, thank you.
I think I missed some.
This will be my last intervention. I don't know if we can use the HIV approach. Like, for instance, the way we actually go about HIV was very, it was like killing the virus. And there was this project that I even participated in Camphia, that we went to every region in Cameroon to determine the incidence and the prevalence. And that was a breakthrough in cancer control in Cameroon. Since cancer, like breast cancer, is becoming a concern, especially with our young girls, is there not a possibility where, I don't know, people like Cindy with their connections and Dr. Mono and even the ministry could come up with a project where we can go to do a survey in most of these regions and to even detect, since detection is a main issue, to increase the level of detection of this cancer and to start now to see how we can manage? Why can't we use the HIV approach in this direction?
Okay, because they are not the same disease. Infectious diseases can easily be enlarged in that way. You need mammograms. Mammograms cannot be done in the simple way that we are looking at it. And we also need empiric data for us not to go screen all young girls. We have had cases of young girls with breast cancer, yes. But we need to re-stratify. We need to do other types of studies first to figure out how our demographic is. Who are those who are having early stage breast cancer? Is it coming from a particular group of Cameroonians? Is it from a particular region, a particular tribe? So we need to understand that data and how it differs. So research is the first thing. We need publications, we need research in order to put investment in place. And the investment for cancer is completely different from investments from infectious disease. HIV, you can do a one-spot test. You can decide to test everybody in the village. And it's easy to do that, but you cannot really move mammograms that way. And it becomes very complicated. So this is a very complicated problem that we need to reflect on. and see if we're using our resources well. The government is already doing a lot for cervical cancer, which you can easily do pap smears and test women, and it's more of a cancer for young women. The truth about breast cancer it's still not a cancer of young women, though we have young women having it. The biggest risk factor for breast cancer is being a woman. I always tell my patients that it's not because you had a BRCA gene, it's being a woman. That's the first thing, because breast cancer is 150 times more common in women than men. That's the first thing you should know. The second risk factor is age. As we age, you get breast cancer. Same thing with prostate. That's the two first biggest risk factors. Then the third becomes genetics. Now, figuring out the genes and making sure that we are in the right framework and we're testing the right people becomes very complex. Correct. But Maloba, that's something we as a group, we as researchers, we as scientists, all scientific research starts with observation. We should do our observations well, document them, get to do better retrospective studies, and then we get that data, and then we are able to do correct prospective studies that will place our money where we have limited resources. The Cameroon government is fighting HIV, they are fighting malaria, they are fighting yellow fever, they are fighting monkeypox. They don't have resources that are available that they can use for everything. So we need to really tailor that. I'm not trying to protect them, but we need to tailor it the right way. And I will not advocate that we do the same screening the US does. The US does screening from 40 and yearly for every woman. We can at least start 40, and every 2 years, it's going to catch a lot of those cancers. Or we start 50, like WHO recommends, and every 2 years. The UK does 50, and every 2 years. Even the UK, which is a first world country, they do that because they feel that they are using their resources better. But if a woman comes to you, I've always said, a woman comes to you that I have a lump in my breast, and you're a GP and she's young, don't take it lightly. Let that lump be evaluated by Dr. Tazeh. You should send that lump for them to do an ultrasound and be able to make sure that they justify this young girl that because you're living in an environment that this is not cancer. So as Sidney made it clearly, there is this, most people thought is just telling women to do self-breast exams. No, it's breast awareness. That's the way we use, that's the term we use now. Know your breast. If anything changes in your breast that is unusual from the normal breast, your nipple is invaded, anything changes from your breast that is abnormal, then see your primary care. And the primary care should also be educated enough to know the test order. And that's what we'll talk about next week.
Thank you, Dr. Mono. This was very insightful. I just have a question if anyone else doesn't have a pressing question right now. Dr. Mono mentioned research. Research is important. So I wonder, is there any registry in place right now at Clear Radiology, which actually captures the data on the recommendation and also the number of women who are positive for any malignancy, including breast cancer, and also the follow-up care, the survival rates of those women since you have partner managing those patients? That's the first questions. And regarding the Maloba's question earlier on why those women come late at the screening, I think this is not only an issue of cancer in Cameroon, it's an issue at large about seeking care early. There is a number of papers actually which have been published around the low trust that patients have with the medical care. So I think what Sidney is doing in terms of awareness is actually testifying a testament to, I would say, some of the aspect why there is low trust among in medical care, particularly the change that he has mentioned in the practice. So more doctors are not aware that they need to request for biopsies. They need to look for staging. And if you compound that all together, I think even patient feels that there is something that is not quite right also with our local doctors. So that might be a reason why in cancer in particular, those women come late, but this has been well documented in Cameroon. People are seeking care late for the lack of trust in our medical system and also affordability. So I wonder if there is a registry capturing all that, including what I just mentioned, which can be termed as social determinant of health as well. So, en français, la question qui est posée simplement, c'est de savoir s'il y a un effort de recherche au niveau de registre pour capturer les données des femmes qui sont en fait dépistées au niveau de leur statut, donc de stage, et aussi au niveau de la prise en charge, quelle est l'issue en fait de leur traitement. Et le commentaire qui a aussi été fait, c'était pour donner quelques pistes de réflexion sur la question qui a été posée plus tôt. Pourquoi est-ce que les femmes sont dépistées tard au Cameroun? Et la perspective qui a été partagée, c'est aussi le fait que dans la littérature, il a été documenté souvent qu'au Cameroun, les personnes atteintes de n'importe quelle maladie ne recherchent pas les soins parce qu'il y a un manque de confiance en la capacité du corps médical. Et je me suis un peu avancée en précisant que dans la présentation de Sidney tout à l'heure, il nous a parlé du changement d'attitude au niveau des médecins locaux qui maintenant demandent des tests qui sont des tests élémentaires pour la prise en charge de femmes atteintes du cancer du sein ou suspectées de cancer du sein, notamment la biopsie. Donc, il y a un changement d'habitude qui n'existait pas avant. Alors, cela peut aussi impliquer que les patients eux-mêmes ne se sentent pas confortables vis-à-vis de la prise en charge et donc cherchent à se faire dépister tard. Donc, la question pour Sidney, c'était de savoir quels sont les efforts au niveau de la recherche de mettre en place un registre pour ces femmes qui passent par son centre.
Bonsoir à tout le monde. Docteur Mouélé. Oui, je peux m'exprimer?
Yes, oui, oui.
Oui, alors je suis le docteur Mouélé. Je suis chirurgien, oncologue et scénologue à l'hôpital gynéco-obstétrique et pédiatrique à Yaoundé. Alors, pour les registres de cancer au Cameroun, bon, je vais parler de mon service. Premièrement, parce que dans mon service, j'ai mis sur pied une sorte de registre avec tous les patients qui sont diagnostiqués d'un cancer du sein. Ils sont enregistrés, c'est-à-dire avec les stades, avec les classifications, les traitements, tout. Alors, mais au niveau national, il faudrait vraiment qu'on ait des registres qui vont représenter toute la population, enfin tout le Cameroun. Parce qu'actuellement, on peut demander quels sont les chiffres au Cameroun en 2024, personne ne peut répondre. Parce qu'on n'a pas de registre et ça nous limite. Bon, maintenant, pour les patients, je vais répondre maintenant à la deuxième question. Les patients qui viennent à l'hôpital à un stade avancé, ça s'explique de plusieurs façons. Déjà, il y a la culture. Hein? Il y a beaucoup de gens qui préfèrent rester avec une masse dans le sein et se dire, ah, si on me dit que c'est un cancer, je ne pourrais peut-être pas me faire soigner parce que je n'ai pas les moyens. Voilà. Donc, il y a d'autres patients qui, quand même le cancer, la maladie est diagnostiquée, faute de moyens, ils n'arrivent pas à se faire soigner. Il y a également d'autres qui, malgré que le diagnostic soit posé, il n'y a pas suffisamment de traitement, suffisamment de traitement au Cameroun pour pouvoir les soigner. J'ai parlé de la radiothérapie tout à l'heure. Nous avons la radiothérapie à l'hôpital général de Douala, où c'est un appareil, la colbatothérapie. Or, vous savez tous, je pense que vous êtes tous des spécialistes, que maintenant, c'est les accélérateurs linéaires qu'on utilise dans dans les traitements des cancers en radiothérapie. Alors, il n'y a que le COC à Bekoko, à Douala, qui a l'accélérateur linéaire. Alors, toute la population du Cameroun, chez qui le diagnostic est posé, où est-ce qu'ils vont se faire soigner? Donc, c'est autant de questions qu'il faut se poser. Merci.
Thanks, Dr. Moel. I think if I understood you, starting from the last question about, yes, we only have one radiation oncology facility that I know of in Cameroon that is operational right now, and it's in Bekoko. I know there's one in Bamenda that is being built. That's probably still a couple of years out. But yes, like I mentioned in my slides, we are striving to make progress, not for perfection, and not everybody needs radiation. Not every cancer patient. Okay, sometimes chemo, surgery, hormonal therapy is all you need, and looking at going from nothing, no treatment, you sit there and literally just wait for the cancer burden to just keep going up and up, to getting some kind of treatment is progress. And from my vantage point, that's kind of what we are pushing for, being that pragmatic, trying to make steps going forward. COC is already in the process of getting a second bolt on site, a second linear accelerator to go up. And so that's going to be coming. So yes, we would have to accept that, so there are some patients that are going to need radiation that are not going to get it, but as long as they're getting hormonal or chemo, it's better than nothing that I would have gotten a few years ago. So that's that. And then to Dr. Polo's question about the registry. So yes, sometimes the word registry sounds fancy, right? So it's a big word, registry. But yeah, so we do have a registry at CLAIR, and basically, I mean, registry just means a place where we put all our data, and then we can aggregate it and analyze it. So yes, we do collect that data, and we are going to be analyzing it to see what kind of trends we can see. However, like Dr. Mode said, you need a national registry, right? You need to look at a large pool of data. However, that does not stop a well-organized clinic, a big clinic, to be able to put out some what they call single institution experience, right? You can put out what you guys have observed based on your clinic. It's still good usable data. So I know a year ago, and we had somebody in the town hall that talked about a national registry that the Cameroon government was going to start. I don't know where that ever ended, but my recommendation is that should not stop every clinic to make sure that data is well collected, well tabulated, and locally analyzed, so that whenever that registry comes, then we can aggregate that data, then we can start seeing patterns. So CLAIR is definitely going to be, that's what I'm going to do. In a year from now, I'm definitely going to be able to come to the town hall and say, based on what our experience in Boya, here's what we're seeing. Now, that alone, obviously, it's better than nothing. And to me, that is progress. That is progress. And that's what I'm striving for every day.
Just to add, Dr. Polo, those who are here to know exactly, I work a lot with a lot of hospitals in Cameroon. The Baptist Mission Bingo, all the Bingo hospitals have an excellent registry up to par with that of the US. Even the softwares they use is the same software we use in the US. So Bingo actually has one of the best data you can get, cancer registry data you can get in Cameroon. They use the best softwares. They have access to it. All patients are registered, stage, everything. So Bingo is already doing that. Dr. Kuya, Francine, is going to tell you that. And we work a lot with a lot of patients. And we collaborate a lot, even with the radiation oncologist who is there, who is still waiting for his machine to start practicing, but he's helping out. So Bingo, the Bamenda Regional Hospital also started a registry. So we do work with them. They started a registry and they're very serious about it. There are multiple other hospitals. I know L'Hôpital General Yaoundé used to have a registry. I don't know what the state is now. And also Ash Gopi, as Dr. Boyle told you, his service. There are many others that have. And Professor Ndom started a national registry. That's where we had the initial data. But I think that had lost track. And that has fallen off. Cameroon actually had a national cancer plan by 2024, which was built with the Clinton Foundation and the Gates Foundation. There was a whole collaboration, making sense of what is going to go on and the progress. But that whole project, which I have a copy, not much has been done, but some things in the project have been established. At least we're training oncologists in Cameroon right now. We're having gynecologists and surgeons go out for subspecialization. We have some radiation oncologists who are there, though we don't have, the government does not have any single linear accelerator. There is Dr. Anne Mad, who is in L'Hôpital General. There are many others. So there is Dr. Mapenya, who is in l'Hôpital Général in Yaoundé. And we need to invest in some of these things to make the things run. And I think maybe with time, we can get Professor Ndom to tell us all his efforts. He has done a lot of efforts in cancer, though things didn't really move very well. But it's a field where, as you said, the more we get data, the more we emulate bingo and the Catholic Mission, Shishong, and bingo, and do what they're doing, and get into the private sector like what Sidney is doing now, we would have enough data.
Yeah.
And in-hospital cancer registries are good, but you need out community oncology registries for us to be able to really understand what is happening.
Correct.
Yeah, so that part of the question, I think that's what I can add after working and collaborating with those in Cameroon. There's a lot going on in Cameroon, which is a good thing. The regional hospital is doing a very good job, and they are learning how to collaborate with bingo, and so that they can make good use of all the specialists who are in the Northwest region in order for their patients to have the best experience. I hope other regions do the same. I've attended tumor boards in both areas. I was very disappointed. That's why I feel education is still the best way for us to move forward. How do we train our doctors back home? How can they use the diaspora to improve what they are being trained for? I attended La Cantine's tumor board. I do tumor boards here every day. Some of them were my professors there, but the approach was more like a professor trying to ask questions to other young doctors who are coming to present their cases. That was not the goal of a tumor board. The goal of a tumor board is for every specialist who is there. The pathologists were not even presenting the pathology. They were not even allowing the radiation doctors to present. They were not getting those kind of inputs that you need. But the goal of a tumor board is for everyone who is taking care of this patient to put in their input and say where the problems are so that we can come out with solutions. So these are all little things that we can use the diaspora better in Cameroon to help and assist training. We can work together and also use those who are in Cameroon and collaborate. And one thing is always a take-home message. Cancer, you cannot treat cancer alone. Cancer is not one of those specialties that you can sit in your office and do surgery and say you're done. You need to be able to talk to the medical oncologist, especially I'll take the case of a patient with hormone-positive breast cancer. The surgeon will need to do a lumpectomy. If they cannot get radiation, that's not adequate care. The patient needs radiation if they're getting a lumpectomy. So don't just do a lumpectomy in your office and say that's all. And it happens in Cameroon if you don't collaborate. After radiation and lumpectomy, that patient needs hormonal treatment for 5 years at least. The patient needs risk stratification if he's going to need chemotherapy, either an oncotype DX, which is not done in Cameroon, or needs other forms of risk stratifications, which Sidney had presented in his last talk, which we had. You see, those things are, it's a team sport. No job emulates in healthcare like cancer being a team sport. So we need to learn to know that you can no longer work in silos. We need to collaborate. We need to call each other, have the names of the doctors, and work together.
And just to add one other thing also, which is important, is at the level, the registry is how we move the whole community, the whole country forward, and how the government makes public health decisions, how they spend money, where their funds go. But even at the level of the clinic itself, right? At the level of the clinic, at the level of the patient, there are patients that you have to follow them up over years because you found something suspicious, maybe some microcalcifications, whatever, or suspicious nodule. Sometimes you got to follow them up time over time over time. Even in the US, when I first started in this field, it wasn't uncommon for patient records to go missing. But now with online registries and PAC systems, then that's something that directly benefits the patient today. So even without us having a national registry, hospitals that are well organized, that are really trying to do the right thing, would still make sure that those records are kept and used to monitor that patient, so that when it's time to intervene, they're like, okay, this mass is really growing, or there's something wrong based on your previous scans or your previous reports, then we need to intervene. So that's where that comes into play today. So again, so my summary is that let's not wait for this big thing that should come for us to move the society forward. We can use that data right there to make decisions at the level of a single patient who comes in year over year for routine mammograms, as an example.
Thank you. We are almost at the hour. I have one last question. or maybe we have a time to take two, Elvis, I don't know. So the question is, so you talk about cancer is curable, breast cancer in particular. I wonder if you can comment on two things. One is the affordability, because cancer is curable, at least when detected at early stage, if there is access to treatment, meaning if there is someone there to pay for the treatment. So I wonder, how do you manage those patients? How do you decide basically who's going to get assistance? How is that assistance plan is worked out? That's the first. And then the second question is more around how do you leverage, how do you collaborate with local doctors in terms of changing their practice? What are the tools that you put in place? You mentioned in your presentation the case where some doctor requests an MRI for a farmer, and you basically use another test. Maybe I've heard that wrong. So yeah. How do you convince the local doctor that this was not the right test to do? And what are the materials that you put out there for doctors in terms of helping them understand that they need to actually order the proper test without actually bruising anyone's ego? Les questions, il y en a deux. La première question est sur le titre, en fait, de cette présentation où on a dit que le cancer est curable s'il est détecté tôt. Et le commentaire qui a été fait, c'est s'il est détecté tôt, quand Sidney, c'était de savoir quel est son plan d'assistance financière pour ces patientes-là qui ne peuvent pas se permettre le traitement. La deuxième question, c'était quels sont les outils en place d'apprentissage pour les médecins locaux pour leur permettre, en fait, de changer leur pratique. Parce qu'il a mentionné dans sa présentation qu'un patient, un agriculteur, avait été prescrit un MRI, donc une résonance magnétique, et ce patient-là n'avait pas besoin de ce test, donc il a pu changer la prescription pour l'examen médical. Alors, c'est de savoir comment est-ce qu'il s'y prend sur le plan pratique pour, en fait, aider à changer la pratique médicale localement.
Yeah, thank you for that question, and I'll probably just answer the second one first. So this particular case was somebody who came to Claire, went online and asked us if we did MRIs. Now, we do not offer MRIs at Claire yet, and as part of our follow-up, as part of our practice, we didn't just say, hey, we don't do an MRI and then stop there. We asked why. Hey, can you tell us why you need an MRI? And then they presented us with the case. They said, hey, my dad, blah, 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 blah. They gave us the details. And then, of course, I called up my, I've treated prostate cancers for a long time, but I got a tumor board, right? I called up Mono, I called up a few people, urologists, and we discussed the case. And obviously, we're like, no, we should not get an MRI, because in that particular case, just a repeat PSA is the first thing you do, okay? A repeat PSA. And then there's no point to go and get an MRI when you've never done a biopsy. So, yeah, and in cases like that, that is where it gets really hard now, because you have to now be able to explain that to the doctor. And the first thing, and this is for all of us who are here in the diaspora and also those who are in Cameroon, but the first thing I learned about people's skills is that you should don't be arrogant when you're talking to another professional. Us here in the USA, we are never. Somebody talked about us getting dual citizenship. That would be a big step. That will make a big difference. But as long as I'm resident in the US, in no way can I ever dream, or Dr. Muno, or any other Dr. Foyon, that they can make that impact in Cameroon, like the doctor who lives in Cameroon Monday through Friday. So the best we can do is to try to educate them and as much as we can. Now, when you're on the ground for a while, you tend to know who you send your patients to and who you don't send your patients to. Okay, but I would strongly, yes, treat people with respect and And there are ways which you can educate somebody without being dismissive. Because then, remember, at the end of the day, you have a patient that you're trying to save, not your ego or the doctor's ego. You have to try to save that patient. So I can't tell you a number of times when either my doctors in Cameroon have called the referring physician to discuss with them, or myself, I've spoken to the doctor, say, hey, here's what we think. And we make sure that we're making that decision together. Because again, we are on the same team to get that patient the care that they need. For your second question about affordability and who gets care, who doesn't get care, I'll talk about Claire. I know for other centers they do a sliding scale. We do something similar to a sliding scale, but our biggest way that we help patients to pay for the scans is through funds that every day I probably spend 10% of my time trying to raise money for Claire Medical Foundation, which is used to help patients subsidize not only the testing, but just also giving them money for transport. So yeah, when somebody comes in, somebody will come and say, hey, I only have 10,000 for a mammogram that is 17,500 or 25,000 or whatever. We're not going to send that patient away. We might not do the test today because we don't have the funds, but we are going to keep that information and then we're going to try to find the funds. I will not guarantee those funds are always going to be available, but we would do our best to try to subsidize. We never pay 100% for anybody's scan. Almost never. I don't think I've seen that since I've been at Claire, because you don't want people to think, you don't want to quote unquote train people that they can just walk in and get a free scan. But again, yeah, so it's similar to a sliding scale, but it's more of a individual. Whenever a client walks in, we have to assess them based on the information that they give us. And also, sometimes half the time you realize that the test they're trying to get is not even what they need. So like the MRI case, then you have to educate them. So it's tricky. There's no black and white way of paying for scans. Treatments are obviously a lot more expensive than diagnostic testing, but you will not want to go and get started on treatment if you have not had the accurate diagnosis, else you stand the risk of wasting so much money. So you have to spend the money you need. Like Dr. Mono said, if you have the last 100,000 francs, get your hormonal testing and get that done before you start thinking about treatment. So it's a cat and mouse game, but we try. We do our best.
You're muted.
I now hand over to Elvis, and perhaps after Dr. Mono. Elvis, I'm not sure if you're with us.
Yeah, I think it's been a great session, right, Matt?
Yes,
so much
absolutely.
learning and so much very interesting questions. And I think the objective of this session has really been attained. We are 6 minutes past the time, and I think it's time for us to wrap up. Maybe we get some last words from our chair before we maybe first of all from Dr. Brian, some last words from Brian, and then from Dr. Mono before we close up. Hi, Brian. Any last words before we wrap up? Okay, maybe I go over to our chair. Some last closing remarks.
Yeah, as usual, I would just like to thank Sidney for always having time to come to the town hall for us to have this discussion. I always call it a discussion, collaboration. Sidney, there's one thing about your quotes which I've always kept in my mind, is that don't let the pursuit of perfection stand in the way of progress. So we must not be able to get to do everything like it's done in the US. We need to find our own way. We need to work it in such a way that our patients will be able to get the right diagnosis, which is most affordable for them, and be able to treat them appropriately. We need to find what is luxury from what is necessity. Can the CT scan get the same information we're looking out from a pet? Can an MRI, can the CT get the same information we're looking for a pet? Is the MRI really necessary? Do we really need to do it? Do we really need to do hormonal testing for breast cancer? The answer is yes, because it changes treatment. But do we need to do next generation sequencing? Those are all things we need to ask. And there is no way for us to know if we don't train this young generation of doctors well. There is demographic shift in epidemiological shift, in our disease demography right now. The way we should train people back home should not only be emphasized in, we have very intelligent doctors back home. There are people we all trained with. They're super smart, but the question is, are they getting the right training that they need in order to be able to fight the wars that are in front of them? Are they being trained for ground war when they're going to be using drones? That's the question, because you don't want to train your soldiers for ground war and someone sits in his parlor and sends drones and destroys all of them. So you need to understand what we are training these doctors for. So going forward, non-communicable diseases, including cancer is one of them, becoming the big priority in Africa? The answer is yes. Is our training adapted for these doctors as a GP to be able to do what GPs are supposed to do in order to screen these patients for those cancers that are screenable and cancers that we can avoid huge mortality by getting early diagnosis? The answer is yes. So I would invite those in the town hall, those who are interested. You join me next week. On Saturday, we'll have detail. This is going to be different. We'll talk detailedly about breast cancer. It's going to be geared towards medical health personnel and also those who are patients who want to join and ask questions and understand it. The information will be put in such a way that it's going to be easy to digest. That's the way I'll put it. And I do treat about 10 breast cancer patients every day. So I know what I'm talking about. So if I'm talking about any patient, what we're going to be talking about is not just fantasy, is what we do and I trained in Cameroon. So we are going to adapt it to Cameroon and share it widely once you get it. We want everyone to be able to attend. And it's part of the Town Hall Giving Back project, where we are giving back in the form of training. And we'll do a series of different series in the future for different diseases. And I think this should be, we'll try to see how we can get credits for this, for continuous assessment credits. So, Sidney, thank you for your time. Continue the wonderful thing you're doing. You are one of our superheroes. You are my superhero. You know that very well. I've told you, you are a doer and not just a talker. So you get things done in Cameroon. And thank you for what you're doing. Elvis, thanks. Over. You're muted.
Thank you so much for the conclusion and very kind remarks. And it's always a pleasure to put this together under your leadership. And we really appreciate all the work you're doing on backstage to make sure that we get all these presentations. I want to thank Dr. Matt Sandrine for the excellent moderation and for the moderating the question and answer session so diligently. For everyone who has stayed up to this point, I want to say thank you. And look forward to seeing you next week for in a fortnight for another edition of the Town Hall. Have a nice weekend, and I hope you are able to watch Francis Ngannou's fight.